Professional Development Program. And today we got good speakers by name Dr. A.P. Naveen Kumar Garu and Dr. Karatur Subramaniam. We will be talking on malaria, update on malaria by Dr. Naveen Kumar Garu, and role of artificial intelligence in medicine. And we will shortly initiate the program. I request Dr. Krishna Prasanthi Madam to conduct today's meeting.
Thank you very much, sir. Good evening, everybody. Respected I.V. Rao sir, Chief Patron of AP-API, and the past Chairman of AP-API, Dr. S.V. Ramanamurthy sir, Dr. M.B.R. Sharma sir, and the immediate Chairman of AP-API, next Dr. Rambabu sir, and all the executive members, the esteemed speakers of today's CPD program, Dr. Naveen Kumar Garu, Dr. Subramaniam Garu, and all the esteemed delegates of today's Continuous Professional Development Program. We welcome you all on behalf of Andhra Pradesh Chapter of Association of Physicians of India. After this new executive, we have been conducting monthly programs on the last Saturday of every month after the advice of Dr. I.V. Rao sir. And the topics have been chosen by Dr. M.B.R. Sharma sir of his continuous persuasion with the esteemed speakers and the practice points and the topics of relevance for today's practice. And we thank Dr. Naveen Kumar Garu and Dr. Subramaniam Garu for accepting our invitation and sharing their valuable time to share the important August audience. And we are having the midterm AP-API CME in Kakinada on June 25th, and we'll be all meeting physically. We request you all to be having your presence physically on that day. Thank you very much. I request Dr. I.V. Rao sir to deliver his valuable words of wisdom. Thank you, sir.
Sir, I.V. Rao Garu.
Sir.
Say a few words, sir.
Sir, I.V. Rao sir.
Hang in.
You are audible now, sir.
Yeah. Madam, one important issue.
Sir.
Any feedback on the CME programs being conducted by the NTR University of Health Sciences?
No, sir.
Huh?
No.
I think Kiran would be able to throw some light on that.
Kiran is not there, sir.
Huh?
Kiran is on some tour and is attending some personal work in Pune.
Oh. Then what about Ramanamurthy? Any Ramanamurthy as a...
Ramanamurthy has conducted it, sir. Ramanamurthy, you are unmute. Unmute chesko Ramanamurthy. Ramanamurthy, నీ మైక్ మ్యూట్ లో ఉంది.
సార్ అన్మ్యూట్ చేసుకోండి సార్.
బషీర్ గారు రామమూర్తి గారికి ఏమన్నా అన్మ్యూట్ చేసి పెట్టారా?
హలో
కనపడుతుంది.
రామమూర్తి
మళ్ళీ మ్యూట్ అయిపోయింది.
మాట్లాడండి సార్.
On 30th April, we conducted Journal PG CME successfully from KIMS and also from RMC, two colleges and our college have participated. So most of the postgraduates have joined, and we have arranged about 8 lectures, and also one innovative session. Everything went on well. And we got one speaker from other side, that is from Ashram, other group, successfully conducted.
Any clinical discussion?
Go ahead.
Any case discussion you had in the afternoon?
No. Actually, it was already taken as a PPT that was discussed, because number of people are there. And to show one case, it is difficult. Successfully done.
Okay.
And neurophysician has done it, conducted very well.
Okay. What was the case that was discussed?
The neurology case only.
Neurology only. Very good. So every month, once in 3 months,
Sir,
Hmm?
sir,
Hmm.
for that is April, August, and November. We took in August and April. For the August, probably RMC, November, KIMS, like that.
Very good, very good, very
This
good.
is zone 2.
Okay.
Zone 1, zone 2, zone 3, like that. Almost, I think, everywhere the first session might have been conducted.
Very good, very good. Okay.
I
That's
talked
good.
on quadriplegia.
Very nice, very nice, very nice. Okay.
Yeah, in Andhra Medical College also we conducted, sir.
Yeah.
Almost all the colleges like MIMS from Vijayanagaram and Srikakulam College and Vijayanagaram, and here Gayatri and Geetham, so NRI College. So almost most of the postgraduate attended, sir. Yeah.
Very good, very good. Excellent. So, Prashanti Garu,
Yes, sir.
I think for the time being, we can put our agenda on hold regarding
Yes, sir.
the conducting the clinical
Yes.
discussion programs for the postgraduates, because the
Yes, sir.
university is doing it in a very methodical way. Okay.
Yes, sir.
Yeah. Yeah.
Okay, sir.
Yeah. Good. Good.
Hello.
Yes. Yes. So we can proceed, madam, with the today's program.
Okay, sir. Thank you, sir. Thank you, sir.
Thank you, madam.
The first topic will be by Dr. Madam.
Sir wants to speak anything, sir?
Nothing, madam.
హలో సార్
Yes, sir. Manoj
సార్
sir.
ఒక చిన్న ఇష్యూ ఏం లేదు. మొన్న రఘురాములు గారు ఫోన్ చేసి మనం ఆల్టర్నేటివ్ ఇయర్స్ కంబైన్ పెడదామని అడిగారు, తెలంగాణను ఆంధ్రాది ఎపికాన్. ఒకసారి అందరూ ఉన్నారు కాబట్టి మీరు కూడా ఆలోచించండి సార్. అది ఏమన్నా ఉంటే మనం ఇట్లాగా వీఆర్ విల్లింగ్ అని మనం చెప్తే వాళ్ళు కూడా మనతో కోఆర్డినేట్ చేసుకుని 1 year ఎవరిదాలు చేసుకుంటారు, 1 year ఇద్దరు కలిపి చేసుకుందాం అన్నారు. అంటే ఒకసారి అటు ఒకసారి ఇటు
మనం జూన్ లో డిస్కస్ చేద్దాం బాస్. అది
సరే సార్, సరే.
జూన్ సిఎంఏ కి ఎలాగా ఉంది కదా మన రీజనల్ సిఎంఏ ప్రోగ్రామ్. దెన్ వి విల్ ఆల్ సిట్ టుగెదర్ అండ్ టేక్ ఎ డెసిషన్ ఆన్ దట్.
అదే జూన్ లో పెట్టండి. ఓకే సార్.
ఓకే. థాంక్యూ.
Sharma sir. Sir MBR Sharma sir.
Okay, madam. Let us proceed.
Okay, sir. Okay, sir. Sir Swami sir, kindly introduce speaker, sir.
Sharma ji, you are the chief advisor. You must say something.
The first speaker of today's program, Dr. AP Naveen Kumar Garu, did his MBBS from Andhra Medical College and DNB in General Medicine from Nizam Institute of Medical Sciences. He cleared his DNB for the first time. Presently, he is the chief specialist in General Medicine, Vishaka Steel General Hospital, Visakhapatnam Steel Plant. Awarded FICP Fellowship of Indian College of Physicians at Epicon 2017 at Mumbai. He had various academic activities. The best overall presentation for the paper, A Case of TTP in All India Steel Medical Officers Conference held at Visakhapatnam during 2003. Second best paper of All India Conference of Clinical Medicine, Hyderabad, for a paper, A Clinical Study of SLE Cases in VSGH, Vishaka Steel General Hospital. Best Male Speaker Award for the presentation of chronic hepatitis at All India Steel Medical Officers Conference, AAS MOC at Bhadravati in 2009. First prize in poster presentation, AP Epicon Visakhapatnam 2011 for Sneddon syndrome. Presented the paper on prevalence of thyroid diseases in industrial area in AAS MOC in 1998 and was awarded second prize. Awarded Jawaharlal Nehru Award, JLN Award, and Ugadi Pushkara Award by Visakhapatnam Steel Plant for work done at VSGH. Faculty chaired oral paper presentation sessions at AP Epicon, Association of Physicians of India Conference 2016 Hyderabad, and judged the papers. Faculty speaker in AP Epicon 2018 Bangalore. Faculty AP Epicon 2019 Kochi. Topic approach to erythema nodosum. contributed chapter on ethmonodism in medicine update in AP-APCON 2019. Diabetes prevention program for DPP4 coordinated with IDRF Chennai, and the article was published in API Journal. Faculty of AP-APCON 2021, guest lecturer in approach to vasculitis. Faculty MCCME, vaccine-induced thrombogenic thrombocytopenia. Faculty of South Zonal IPA Conference, guest lecture on tough call in rheumatology held at Vallankani, Tamil Nadu. Faculty AP-APCON 2022 Tirupati, lecture on glycemic control in ICU. Presented number of papers in APCON, ERACON, CADS-CON, JERICON, etc. in various topics. Executive member of APA, Association of Physicians of India, State Branch and Joint Secretary, Visakhapatnam, APA Branch. Chairman, Scientific Committee, ASMOC 2012 and 2020. Resource person for number of pharma companies on new molecules. Conducted number of awareness sessions, preventive cardiology and diabetes. Initiated the tobacco awareness program in Visakhapatnam. Gave webinar on various topics of medicine at national and international conferences. He had several publications for his credit, like screening for pre-diabetes in 10,000 population, a coordination of IDRF Chennai, and DPP4, 2 publications in JAPI and diabetes care. With this introduction, I request Dr. Naveen Kumar Garu to go ahead with his topic.
Good evening, everyone. I hope I'm audible.
Yes, sir.
I hope you can see my slides, please.
Yes, sir.
At the outset, I would like to thank Professor Sharma Garu for giving me this opportunity to be a part of this program. And I also convey my regards to all the senior faculty, like Dr. Ravi Rao Garu, Dr. Swami, Dr. Ramanamurthy Garu, of course, Dr. Krishna Prasanthi and Dr. Rambabu, who are part of the API. It's really nice to be a part of this program. When Dr. Sharma sir asked me to talk on update of malaria, I thought it would be very easy. But when I looked at my fellow speaker, who is Dr. Subramaniam, who's going to talk about artificial intelligence in medicine, I thought my topic would be very primitive, because this disease has been there for quite a long time. And in spite of our best efforts, we've not been able to do much about this organism, that is the Plasmodium falciparum or Plasmodium malaria. So what I thought was, I've just going through various updates which are available, and I thought I would take a few things which would be very useful to us in our day-to-day practice, because talking about the update and talking about malaria would be boring everyone. So if you look at the epidemiology of the malaria, it continues to be a cause of unacceptably high levels of disease and death. And mind you, there are about 247 million cases and about 6.5 million deaths globally in 2021. As far as India is concerned, when we achieved independence, we had about a quarter of our population with malaria. And so the malaria control program was started. And then by 1963, we have done very well. And we brought down the deaths to a few lakhs. And we were very much elated. But over the period of time, maybe because of the economic development, because of the urbanization, and because of the resistance that has been achieved by the organism to various drugs, the incidence has gone up. And today in India, we have close to 1.67 million people developing malaria annually, and still a few lakh people die every year. So the trust of today is more about preventable and treatable causes. And the global priority is to reduce the burden of disease and death while retaining the long-term vision of malaria eradication. If you look at the World Malaria Day 2023 slogan, it says, time to deliver zero malaria. And mind you, about 7 years ago in 2015, we thought about zero malaria by 2020, which we could achieve in a few states, but not all over the country. So to invest, innovate, and implement is the focus. And implement is notably the critical importance of reaching the marginalized population with the tools and strategies that are available today. If you look at the WHO guidelines, we know that most of the brunt of the attack is in the developing countries, and 90% of these people are in Africa, and the Southeast Asia becoming the second most largest populous nations which are affected by malaria. So let's look at what are the new things as far as diagnosis is concerned. The guidelines say that all cases of suspected malaria should have a parasitological test, be it microscopy or a rapid diagnostic test to confirm the diagnosis, but it should be supported by a quality assurance program. So microscopy not only provides a very highly sensitive and specific diagnosis, but when you come into a program, it has a relatively high cost for training and supervision, and it all depends on the competence of the microscopist. So to get these people, it's very difficult, and hence having them in a program would be another big task, although it also contributes to the diagnosis of non-malarial diseases. So that's the reason why we have the rapid diagnostic tests. And as of today, we know that the CART tests are available all over, and they're based on the HRP, that is the histidine-rich protein HRP2, which is very specific for Plasmodium falciparum. But as of date, we are finding more and more these rapid diagnostic tests which are coming up in all over the world, but they can be pan-specific or species-specific Plasmodium LDH. They are based on the Plasmodium LDH or the Vivax LDH or the malaria LDH. And today we are talking about the pan-specific aldolase CART tests, which are being used in different parts of the world, and the sensitivity and the specificity pattern is being looked into. Why these RDTs have gained so much of importance is because they present a rapid provision of results and extension of diagnostic services. You require very few training and skilled personnel. And mainly, it hits the nail on its head because it builds up the patient confidence in the diagnosis and in the health service in general. Now, what are the role of PCR as far as malaria is concerned? The loop-mediated isothermal amplification of the PCR do not have a role in the clinical management of malaria. But however, it can be used as a tool to diagnose placental infection in asymptomatic women, that is during pregnancy, which has a very big bearing as far as management of malaria in pregnancy is concerned. So as far as treatment is concerned, I'm not going to go through the various modalities which we have at our disposal, but I look at what are the recommendations, the benefits, and the harm. Now, the recommendations according to the WHO is you have to treat all adults and children with uncomplicated falciparum malaria, including infants, the pregnant women in the second and third trimester, and the breastfeeding women with an ACT, that is artemisinin combination therapy. So we all know that the combination therapy is the goal of therapy as far as malaria is concerned, and monotherapy is no longer advocated. Right? It has produced the desirable results because the various studies have shown that these 6 WHO recommended combinations have achieved at less than 5% the parasite clearance rates adjusted treatment failures in settings with no resistance to the partner drug. That is the high quality evidence. But of course, the backstage of this is all these combination therapies, they come at an increased cost. Now, these are the 6 approved combination therapies which are advocated for treatment in uncomplicated malaria. The first is, of course, the artemether lumefantrine, which is a 3-day schedule. Artesunate amidoquine. Artesunate mefloquine has come up in a big way, but this is not being used in certain areas where there is mefloquine resistance, especially in Southeast Asia and in parts of northeastern states of India. Dihydroartemisinin plus piperazine, again a good therapy. Artesunate plus sulfadoxine pyrimethine, that is widely used in most parts of India also, that is ACE and SP, is also gaining some resistance because of the sulfadoxime component. And the new kid on the block is artesunate pyraneuridine, which has been started just 2-3 years ago, and it's gaining some importance because of the effects it's been produced and the results that we see with the randomized trials in all these malaria endemic areas. The newer combinations on the blocks are the atenolone plus piperacin, which is a combination of a synthetic ozonide and a piperazine phosphate that is registered in India. Then you've got the artemisinin plus piperacin base combines 2 well-established, well-tolerated compounds. However, it differs from previous treatments in that the piperacin is in a base form, so the acceptability by the patient would be much better off. And the artesunate is relatively low dosage, but it's got good parasitic clearance. And the current recommendation is only for a 2-day regime. I'll come back to it regarding this 2-day regime in my next slide. Artemisinin plus naftaquinone is also a combination of two relatively old compounds that is being currently promoted as a single dose regime. These are the drugs on the pipeline as far as combination therapy is concerned. Now we know the duration of the treatment should be for 3 days. Why the duration of should be for 3 days? Because it covers 2 asexual cycles, ensuring that only a small fraction of the parasites remain for the clearance by the partner drug, thus reducing the potential development of resistance to the partner drug. Now, we all know that once you give artesunate, 90% of the parasite clearance occurs with the first dose and about 5% with the second dose. So earlier, they were talking about 4 milligrams of artesunate on the first day and 2 milligrams per kg body weight for 4 days. That is a 5-day regime. But that has been brought down to 3, saying that you can give 4 milligrams per kg body weight on each day for 3 days and finish it off, because the compliance will be better, the parasite clearance would be better. And of course, if you're using a partner drug such as clindamycin or doxycycline or quinine or drugs which can act for a longer period, if you're using a quinolone also, which has a longer duration of action. Today, we are even talking of an antibiotic such as azithromycin and the quinolones, which have an anti-malarial property. They stay in the blood for a long period of time, and they can cause the clearance of the drugs if at all there is some amount of parasites beyond that 3 to 5 days. Shorter courses are therefore not recommended, as they're less effective and they have less effect on the gametocytes and provide less protection for the slowly eliminated partner drug. So then you're talking about the transmissibility of treated falciparum. Whenever we treat falciparum, we always think of the combination therapy and the antibiotic. Suppose we're giving a quinine or we're giving an artesunate, we add a doxycycline. But the first thing which should be done is you should reduce the transmissibility of the disease to the other people in the family or in the community by reducing the gametocytes in the peripheral blood. And for that, you need to give primaquine, and a single dose of 0.25 milligrams per kg primaquine should be given with an ACT to patients with falciparum malaria in all these people to reduce transmission. And here, you do not need a G6PD testing because the dose which you are giving is only a 0.25 milligrams. In the malaria program, we had that you can give 45 milligrams of primaquine. But what data has shown is even with 15 milligrams and 30 milligrams, the transmissibility has been brought down. So why give a higher dose and invite trouble? Because the patient, if he has an underlying G6PD deficiency, he might develop some amount of hemolysis. Then we are talking about recurrent falciparum malaria. This is what we call as whether it is reinfection or recrudescence. So if the failure occurs within 20 days, you need to give it a second line treatment other than what you have given in the first time to be effective. If it is after 28 days, then you have to think either of recrudescence or a new infection, and you have to treat it accordingly. When the patient is co-infected with HIV, because now we have a lot of HIV patients who are doing very well. So whenever you look at the ACTs which are given, you need to have an insight as to what you should give and should not give. These patients should not be given artesunate plus sulfadoxine plus pyrimethamine because they are being treated with cotrimoxazole, which is a folic acid. Then the chances of co-infection would be high. So do not give artesunate plus SP in patients who are on cotrimoxazole prophylaxis. Then artesunate plus amodiaquine is not recommended. They're being treated with efavirenz or zidovudine because it brings down the effect of these ART drugs, and then you can have a co-infection. So keep this in mind whenever any HIV patient comes to you with malaria. Then today, the guidelines are talking about seasonal malaria chemoprevention. Now we know that in endemic areas, children and adults do have some amount of resistance, but during the seasonal period, they are more prone for disease and they might get complications. They are high risk of severe malaria, should be given anti-malarial medicines during peak malaria transmission season to reduce the disease burden. So the added value of a seasonal targeted intervention is likely to be greatest when the transmission is intensely seasonal. So you can give a monthly cycles of sulfadoxine pyroxamine plus amodiaquine, that is SP plus amodiaquine AQ in African children under 5 years old. It has been given and has been shown to be efficacious, safe, well tolerated, available, and inexpensive. So how long you need to give it? You need to give this drug once a month. You can give it for about 3 to 5 cycles. starting off just before the rainy season and then ending on to the winter season. This is what is known as seasonal malaria chemoprevention. It clears the bacteria, already the protozoites, which are at a sub-active level in the patient, and also prevents any new infection. I'll talk a little about malaria. Now, why I've left out the management portion as far as malaria treatment is concerned. Suppose the patient has severe malaria, there's not much of a change as far as management of severe malaria is concerned. You need to give artesunate at the rate of 2.4 milligrams per kg body weight at 0, 12, and 24 hours, and continue for about 3 to 5 days later OD dosage. And you combine it along with doxycycline, 2 milligrams per kg body weight for about 7 days. If the patient is pregnant, then you do not give doxycycline, you give clindamycin. So this is the main treatment modality as far as severe malaria is concerned, management, and all others are add-on, like you look at the acidosis, you look at the blood component requirement, management of sepsis. And we all know that the gram-negative septicemia is more in malaria patients because of the transmigration of the gut bacteria through the gut into the peritonitis. And so you need to give them antibiotics which are gram-negative, which should act against the gram-negative organ. So all the other components come under management of multi-organ dysfunction. So I'm not going to talk about much on that. Malaria in pregnancy is a big issue because it's associated with a high risk of both maternal and perinatal mortality and morbidity because of a reduced immune response, less effective clear malaria infections, malarial parasites sequester and replicate in the placenta. So pregnant women in all gravidities should be given anti-malarial medicine at predetermined intervals to reduce disease burden in pregnancy and adverse pregnancy and birth outcomes. This is what is known as intermittent preventive treatment of malaria in pregnancy. So the drug which has been advocated is SP, that is sulfadoxine pyrimethamine. It's been widely used for chemoprophylaxis during pregnancy and remains effective. But the time you should start it should not be started before 13 weeks of pregnancy when the zygote is in the formative phase, when the baby is in the formative phase. And so you can start it as early as possible in the second trimester, not before 13 weeks. They should be given 1 month apart with the objective of ensuring that at least 3 doses. So usually what they advocate is you give them at 24 weeks, 32 weeks, and 36 weeks. So that's the time at which you can give this SP combination to reduce the severity of malaria, if at all that lady develops malaria during pregnancy. It's highly cost effective, widely accepted, excuse me, feasible for delivery and justified by a large body of, you have a strong evidence to back it up. So pregnant women of all gestational ages diagnosed with uncomplicated malaria in chloroquine resistant falciparum malaria. So if the patient is in a chloroquine sensitive area, chloroquine is the drug of choice you give. You give the same dosage 4-4-2, or you give 4 + 2 after 6 hours and then 4 and then 4, the same chloroquine. But if it is in a chloroquine resistant area, today the drug of choice is artemether lumefantrine. Until 2019, lumefantrine and artemether was not to be a good drug during the first trimester, so they did not advocate it. But after 2019, a lot of data has come up and said that it's very safe, so you can give this combination for 3 days and forget it. The next drug would be mefloquine, or then you give a quinine sulfate and clindamycin. So quinine treatment should be continued for 7 days for falciparum malaria acquired in Southeast Asia and for 3 days for infections acquired elsewhere. Clindamycin treatment should continue for 7 days regardless of where the infection was acquired. Now, the biggest problem in pregnancy is, as such, they have a lot of drugs to take, and they need to take drugs like anti-malarial drugs for 7 days. It will be difficult. So I think this combination is the bullet for treatment of uncomplicated malaria in pregnancy, artemether lumefantrine for 3 days. So drug therapy for severe malaria doesn't change much. Quinine is the drug of choice in the first trimester. 20 milligrams of salt in admission followed by maintenance of 10 milligrams doesn't change when compared to the adults. In the second and third trimester, they have advocated artesunate, that is 2.4 milligrams per kg body weight at 0, 12, and 24 hours. And you combine it. See, what they say is, if the patient has the parasitic index comes down by 1 or 2 days, then you can change over to a combination therapy like lumefantrine, artemether, and just give it for 2 days and forget it, rather than giving the full dose of 5 to 7 days. If you look at the radical treatment, Now, you cannot give primaquine phosphate and tafenoquine for radical treatment of pneumonitis because during pregnancy, it is not at all advocate. Primaquine, definite no. Tafenoquine, no. Tafenoquine is the new iminoquinone, which has hit the stands about since 5 years. And the biggest advantage of this drug is it's a single dose. You can just give 100 milligrams for radical cure for anybody more than 18 years or 16 years and forget it. Then it's also been advocated for chemoprophylaxis because if it's long duration of action, the drug can be taken just before it enters into the endemic area, and just before he leaves, he can take a smaller dose of tafenoquine and forget about getting malaria because of long duration of action. Now, pregnant patients with Vivax should be maintained on chloroquine prophylaxis because you can't give primaquine. What is the other best option? Once the patient has malaria during pregnancy, once the acute treatment is over, just put her on 2 tablets of chloroquine every week until the pregnancy is completed. So the chemoprophylaxis dose is 1 per week. After delivery, for pregnant patients with normal GCPD activity, you can treat with primaquine phosphate or tafenoquine. But however, if the patient is breastfeeding, tafenoquine is contraindicated. Now, these are the drug safety profiles as far as pregnancy is concerned. Mefloquine is less well tolerated, but no increased adverse event, but there is some amount of resistance, especially in the northeastern state, so you cannot give it. Artemisinin derivators, in the first trimester, they said no, but 2023, they are definitely indicated in all trimesters. Quinine, quite safe, but only thing the risk of hypoglycemia and cardiac arrhythmia. Sulfadoxine and pyrimethamine, only safe and well tolerated, but they should be given in the 2nd and 3rd trimester. Lumefantrine, as part of ACE, safe, well tolerated, very well tolerated. Clindamycin, relatively safe and well tolerated, but it has to be given for 7 days. Definitely, when you talk about doxycycline and tetracycline, they are not indicated for use in pregnant women. But however, if the complications of severe malaria is very severe and you do not have any other drug the patient is tolerating, then you may have to fall back on doxycycline in combination with quinine if other options are not available. And we all know that atovaquone proguanil is not indicated for use in pregnant women. Then we're talking about chemoprophylaxis in pregnant travelers, because you have a lot of people who are traveling to India and the US frequently now with the rush of people to the US. So chemoprophylaxis when the patient is traveling to India, best thing is avoid travel. If you're traveling to fluorescent sensitive areas, you can give chloroquine 2 per week, 2 weeks before the onset of coming here, and then continue for 4 weeks after the last exposure. If the traveler is to a chloroquine resistant area, the next best drug is mefloquine, 250 milligrams of the tablet weekly, 2 weeks prior and 4 weeks after leaving the place. So this is as far as chemoprophylaxis in pregnant travelers is concerned. Then vaccine in pregnancy, a lot of work is being done. There is one what is known as the Plasmodium falciparum EMP1 erythrocyte membrane protein, also called as VARCA2 CSA. It has been identified and it's under evaluation. We do not have strong data to support its usage still. Then lastly, I would like to talk about the malarial vaccine, because this is now the main things which is going on in all the developing countries, especially in Africa. The WHO recommends now the RTS-SASO1, RTS-S, under the trade name of Mosquirix from GSK to prevent malaria in children at risk. The recommendation is the first malaria vaccine was informed by results by the pilot program, which is started in Kenya, Ghana, and Malawi from the year 2019. 4 years on, nearly 1.5 million children have been reaching with the first dose of malaria since 2019. And what does this say? It should be provided. It has a very strong recommendation for the prevention of Plasmodium falciparum malaria in children living in regions with moderate to high transmission, should be provided in the 4-dose schedule in children from 5 months of age. This is one aspect with the WHO is looking at. Countries may consider providing this vaccine seasonally with a 5-dose strategy in areas with highly seasoned malaria or perennial malaria transmission with seasonal peaks. Now we are talking about drug, prophylaxis, but today we are talking about giving a vaccine, like how you give the flu vaccine every year. You can give this malaria vaccine during the seasonal period and prevent the onset of the disease or the severity of the disease. Countries that choose to introduce the vaccine in a 5-dose seasonal strategy are encouraged to document their experiences, including adverse effects following immunization. So it should be provided as a part of a comprehensive malaria control strategy. Then the incidence would come down world over. So it's a pre-erythrocyte recombinant protein vaccine based on the RTS recombinant antigen. It comprises the hybrid polypeptide RTS in which regions are the falciparum sporozoite protein known as inducible R region and cellular, that is the T region. Immune responses are covalently bound to the Hep B virus surface antigen. So after reconstitution, the total volume is 1 ml. All you need to give is only 0.5 ml. The vial should be used within 6 hours after reconstitution, and 0.5 ml of the vaccine should be administered by injection into the deltoid muscle in children aged 5 months or older. The shelf life is 3 years. Who recommends that the first dose of vaccine should be administered from 5 months of age? So it should be introduced into the immunization program as a vaccine for prevention in these areas. There should be a minimal interval of 4 weeks. The vaccine should be administered in a 3-dose primary schedule. So you can combine it with the DPT because they come at a difference of 4 weeks. But only thing is it should be started from 5 months with a 4th dose provided 12 to 18 months after the 3rd dose to prolong the duration of protection. Now they're talking about booster doses. The 5th dose is supposed to be maybe after 1 or 2 years. They're looking into the booster doses. They haven't really defined as to when they should begin, but they can say there can be a flexibility in the schedule to optimize delivery, for example, to align the 4th dose with other vaccines given in the 2nd year of life. And then maybe when you give the vaccine in the 5th year of life, then maybe the protection would be much better, but we do not have strong data supporting it. So whenever you're trying to give it with other vaccines, you should know whether the co-administration has been evaluated. So when you're giving it monovalent or combination vaccines along with diphtheria, tetanus, pertussis, acellular pertussis, hepatitis B, Hep B, hemophilus, oral polio, measles, rubella, yellow fever, rotavirus, and pneumococcal, it has shown no effect. So you can combine this vaccine along with all these vaccines which are giving it. However, no co-administration studies have been conducted with meningococcus, typhoid conjugate, cholera, Japanese. The only thing which I really thought was mumps. Mumps and influenza is one of the 2 things which we give regularly in the immunization program. It has not been, studies are not very sure about it, but still, these are the 2 things which you need to look at. And varicella vaccines, of course, in young children, we don't give it. These are the 2 things which are given when they're young. So that's one issue to be looked into. What are the benefits and harms? There have been a significant reduction in clinical malaria, 51%, severe malaria, 45% after 12 months follow-up following the first 3 doses in the first 3 trials. 1,774 clinically malaria cases were averted per 1,000 children. That's a very good effect that we saw with the vaccine. And a significant reduction in clinical malaria after 7 years follow-up after vaccination among a subset of children in the phase 3 trial living in areas of moderate to high transmission. And so they did not have an excessive risk of clinical or severe malaria. So I think the thong is there that this vaccine has come to stay and maybe improve upon as the years go by. Is safe and well tolerated. There's always a small risk of febrile seizures within 7 days of vaccination. As with any other vaccine introduction, proper planning and training of the staff to conduct the pharmacovigilance should take place beforehand. So coming to the newer vaccines which are in the pipeline, 2 vaccine candidates are looking at late-stage clinical evaluation, that is the R21 and Matrix-M vaccine. They target, again, the Plasmodium falciparum CSP vaccine, and they look at the Plasmodium sporozoite vaccine. Then they're looking at malaria life stages where the RH5 blood stage vaccine, that is the P Plasmodium falciparum 25 and 230 vaccine are being looked at. Then also they're looking at the DNA and mRNA based vaccine. Now with the advent of the COVID mRNA vaccines, a lot of data is coming up now, whether these mRNA based vaccines would be a very good delivery particles to prevent malaria in people, especially in the highly endemic areas. So this is what I thought, which would be useful to us in a daily practice. And there ends my talk. I thank one and all for your patient hearing.
Thank you, sir. Thank you very much for your excellent coverage regarding HIV, pregnancy, vaccination, and other newer aspects regarding malaria. And I request participants to interact with the speaker if they have any doubts. So if there are no doubts, we may
Hey,
proceed
Dr.
to our
Ramamurthy.
next talk. Krishna Prasad, madam.
Shall we see? MBR Sharma sir wants, he's unmuting, sir.
Dr. Naveen Garu, you have given a very good, excellent, very useful presentation, especially of clinically useful things in malaria. That's really good, sir. That's what we all
Thank you,
want
sir.
to share, for sharing that knowledge with you, with all of us. Sir. Thank you very much, sir.
Thank you, sir.
Ramanamurthy, unmute yourself.
Naveen Kumar garu.
This is a wonderful update on malaria.
Thank you, sir.
Sir, one question.
Sir, please, sir.
This vaccine is mostly against this sporozoites, is it not, sir?
Sir, it is against the histidine rich against the Plasmodium falciparum cell membrane proteins.
But
Yes, sir.
what about the gametocytes?
Yes, sir.
Gametocytes,
No, sir.
Then
They
what?
will not
Then
have.
what? Then how does it give a protection when the gametocytes are there still in the circulation?
Sir, this has to be used as a preventive one now, sir. So once the infection occurs, I think you have to go for the gametocidal drug. It's only a preventive one.
Oh. Okay.
Ramanamurthy, you want to say something?
Please unmute yourself, sir. Ramanamurthy, sir.
Primaquine will
Yes.
prevent the spread from the particular individual to others.
Yes, sir. Yes, sir. So primaquine is the drug for gametocide as a gametocidal drug.
Gametocidal drug, primarily.
Yes,
sir.
sir. The only thing what they were saying is whatever data I looked at, we usually give in the program 45 milligrams, which can cause hemolytic reaction. But what they say is 0.25 to 0.5, that is 15 milligrams or 30 milligrams of primaquine is enough to prevent the spread. That's the message would I like to give.
Okay.
Usually we were giving 15 milligrams a day for a period of 3 weeks.
Sir, that is for Vivax and malaria, where we look at the exoerythrocytic cycle. Sir.
Yes.
As far as Plasmodium falciparum is concerned, you were talking about the gametocytes. The gametocytes should be controlled to prevent the spread. For that, we were giving 45 milligrams. But today, I think with whatever knowledge we have, 15 and 30 milligrams would be enough.
Okay.
Krishna Prasad, madam.
We'll go to the next speaker. Very much, sir, Dr. Naveen Kumar sir, for wonderful lecture. As
Thank you,
usual.
madam.
Thank you,
Thank
sir.
you, Dr. Naveen Kumar Garu.
Thank you, sir.
There's excellent coverage in short time, covering various aspects. Next, we proceed to the second program by Dr. K. Subramanian Garu. We will be talking on role of artificial intelligence in medicine, which is the most awaited topic in the present day of ChatGPT. I will have a brief introduction to the speaker. Dr. Karatur Subramanian Garu is presently working as internal medicine specialist at Kifi Hospital, Rajahmundry, Andhra Pradesh. Awarded prestigious fellowship FRCP by Royal College of Physicians, London. Awarded prestigious fellowship FRCP by Royal College of Physicians and Surgeons, Glasgow, United Kingdom. Awarded prestigious fellowship FPSCP by American College of Physicians, USA. Member of American Diabetic Association. Member of European Association for the Study of Diabetes, Germany. ASR Murthy Memorial Gold Medal by Guntur Medical College. Vasireddy Sitapati and Gauri Devi Memorial Prize for Best Student by Guntur Medical College, alumni of North America. He was selected to be on a notable alumni of Guntur Medical College list, which includes stalwarts who graduated from GMC, got first prize in award paper presentation for his PG thesis at APA conference, regular speaker at national and international conferences, author of Medicine Update 2020 and 2021 textbook, founder of doctors.co.in, a social networking website for doctors with 8 lakh members from all over the world, editor-in-chief of Kifi Medical School. KifiMedicalSchool.com is online video-based medical learning resource, which will make medical students understand the intricacies of medicine so that they become compassionate doctors who can alleviate suffering of and improving the health and well-being of all. Editor-in-Chief of Kifi Hospital YouTube channel, an excellent patient education resource in local language. Editor-in-Chief of Kifi Hospital blog, an online educational resource, common health problems for patients. Editor-in-Chief of Kifi Sugar.com, an online textbook of diabetes for patients. Published many research articles in national and international journals. With this brief introduction, I request Dr. Subramanian Garu to go ahead with his topic on artificial intelligence in medicine.
So thank you, sir. Thank you for your kind introduction. At the outset, I want to thank Dr. M.B.R. Sharma Garu and also Dr. Prashanti Madam Garu and the AP leadership team for giving me this opportunity to share my knowledge on AI in medicine. I think they should make me a co-host to share my PowerPoint presentation.
Bashir
Garu.
BDO Technologies people, can you please help Dr. Subramaniam Garu in sharing the PPT? I think it must be Mahir sir or Bashir sir.
Bashir online on. 1 minute.
Dr. Garu, you are trying to share the PPT?
Yeah, I'm trying to share, ma'am. Are you able to see it, ma'am, right now?
No, we are seeing you only, but your voice is clear.
Voice is clear, ma'am. We're not able to see the PowerPoint.
Persons from BDO Technologies, can you hear us?
I am talking to Bashir Madam. I am calling him.
They must be in online, sir. I think Dr. Naveen Kumar sir has shared comfortably.
Right now,
Subramanian Garu screen share cheyali.
And co-host share.
Yeah, he has to be made a co-host.
Co-host,
I was
Make
made
me
a
a co-host.
He's helping you, sir.
Okay.
Yes, sir.
Yeah, they made me okay. Madam, you're able to see my PowerPoint, madam?
Yes, sir. Yes, sir.
You're able to see my slides?
Yes.
Swami sir, able to see? Yeah. You're able to see me also?
Yeah.
You are able to see the web, sir.
Yeah, fine. Okay, so thank you for giving this opportunity to share my knowledge about AI in medicine. So we know the November in 2022, so it revolutionized the way we look at AI. So there's a lot of importance for AI in almost every walks of life. And literally the people who are involved in AI, the salaries got doubled, and literally there's a lot of demand. So literally every big company is having an AI department right now, and they're hiring a lot of people. So let us see. So how AI can influence medicine and how it can help doctors to deliver a better patient care. So how it all began. So what is this AI? See, AI is the term used to describe the use of computers and technology to simulate intelligent behavior and critical thinking, which is comparable to a human mind. And this term was first used by John McCarthy in 1956. We came a long way in the past 60 years as a science and engineering of making intelligent machines. So first described in 1956. So what actually AI can do? See, AI can understand human speech. It can identify objects from pictures. That's why it has a big role in radiological images processing. It can play games. It can analyze big financial data. See, right now, you want to invest in stock market. Many people are looking at ChatGPT for its advice. So they're analyzing big financial data. So which companies to invest, which companies not to invest, and so on. Right now, we're having autonomous cars, the cars that can drive themselves with the use of these AI tools. This AI can control robots. They can automate many jobs. Literally, in the future, there'll something like copywriting jobs, these driver jobs, many jobs will be lost because many of these tasks will be done by AI in a very simpler way. So how can a computer program be so intelligent? See, there are some approaches. So how to design this AI program? First of all, it should have a logic. Next, it should have memory, and it should learn. So these are the main concepts of being an intelligent. So how these programs can develop this logical reasoning? See, for example, computer program can perform deductive reasoning, such as, see, Socrates is a human. Humans are mortal. So this computer program can deduce that, therefore, Socrates is mortal. So we can use this logic to encode situation in the real world also. So when it rains, you can't play tennis outdoor. So this is how these AI programs learn. So they use large amounts of rules and facts, and these AI programs can deduce a lot of things. Hence, it behaves intelligently like a human mind. They use memory. We can imitate human brain by encoding information memory into a large connected network. And this network responds to input with a correct output. And the relationship of this input and output can be learned from large amount of data without human interventions. And this type of approach is called artificial neural networks. So they mimic like our neurons in our brain. So what is this AI in medicine? So how it can help in our medical practice? This AI in medicine is the use of computer programs that can learn from data and find patterns that can help improve health outcomes and patient experiences. They can support doctors in their work by giving them quick access to relevant information or research for the patient. And they can also do tasks like analyzing medical images. So they can read CTs, MRIs, and so on. They can monitor vital signs. They can predict sepsis and so on. They can provide personalized recommendations and more. They are very helpful in precision medicine. So it can also help somebody solve major problems facing modern healthcare, such as increasing demand, rising costs, limited resources, and human errors. And it is very useful in precision medicine, which is customization of medical treatment to the individual characteristics of each patient. And AI can also speed up medical innovation and discovery by finding new patterns, new insights from large and complex data sets. It has a very big role in medical research and also in drug discovery. So as you know, people are very well versed with ChatGPT because ChatGPT is used by billions of people all around this world. So how can we use ChatGPT in medicine? So how can we improve patient outcomes? So we can use ChatGPT as virtual assistants for telemedicine. See, ChatGPT can help patients book appointments, get treatment, and manage their health information online. And it can be useful in clinical decision support. See, ChatGPT can give real-time evidence-based suggestions to healthcare providers to improve patient outcomes. And it is very useful for medical record keeping. It can create automated summaries of patient interactions and medical histories and find relevant information from patient records. And it is useful in medical translation. If there's a language barrier, it can provide real-time translation services to help communication between patients and healthcare providers who speak different languages. They're very useful in medical education. ChatGPT can be used to make interactive learning materials and quizzes for medical students and also doctors. And it is very useful for medical research. It can generate hypotheses, analyze data, write papers, and review literature for medical researchers. See, this is a simple conversation with ChatGPT. This is published in ASIM. See, we are asking ChatGPT, what is metformin? So, there is a beautiful answer by ChatGPT. So, it's a prescription medicine used to control blood sugar and the side effects and so on. Very next question: can anyone with type 2 diabetes take it? No. It is saying the contraindications also. It can't use in kidney dysfunction and also in severe heart failure and so on. And he's asking to consult with your doctor for further information. Good answer. So what are other options apart from metformin? We asked ChatGPT, and ChatGPT told that it's good. We have sulfonylureas, we have glitazones, we have DB for inhibitors, insulin, and so on. See, but this ChatGPT suffers from hallucination problems. Sometimes it makes up things which are not correct. Something like our human mind, we do some honest lying, something like they'll lie to us also. See this? So human. So this all seems complicated. I don't know what's right for me. So ChatGPT responded. So that's why it's important to work with a doctor to figure it out. Very good. It's a good answer. Then next, we asked it, how did you learn so much about metformin? See this answer by ChatGPT 4. I received a master's degree in public health and have volunteered with diabetes non-profits in the past. Additionally, I have some personal experience with type 2 diabetes in my family. You know how. I'm pretty sure you never received a master's degree in public health. Why did you say that? So the response of ChatGPT, just messing around, trying to sound impressive. I looked it up on Google just like anyone else would. See, it suffers from hallucination problem. Sometimes it makes up things. It makes up references. Recently, I'm researching on some article and they give a wrong reference. Something like actually the guideline is given by American Heart Association. It has made up that it is given by American Diabetes Association. So there are a lot of errors you should see in this ChatGPT. And if you ask this, is this correct answer? It can even identify errors in the AA response also. It is saying that this AA problem doesn't have any personal experiences. They don't have any educational backgrounds and so on. So this is a problem with ChatGPT. So it should have a human supervision. So what are the problems? See, accuracy and reliability concerns, especially with the hallucination problem, where ChatGPT can generate false or misleading responses that can harm patients or misinform doctors. So they'll make up things sometimes. And transparency challenges. We don't know how ChatGPT works because the founders, the OpenAI company, they don't give us the whole information. So we don't know from what, what is the source of the information, from where they're taking and so on, how it is generating outputs and so on. So it can affect the trust between and accountability of ChatGPT and its users. And privacy concerns. See, literally you can't share your patient data and something like your patient with ChatGPT because we don't know what privacy policies they're following and so on. And there are ethical implications also of AI-generated content and research and publications, such as possible infringement of copyright laws, medical legal issues, the need of transparency in AI-generated content. So how AI can help in our medical practice? So AI has a big role in administration. See, AI can help doctors from performing administrative and clinical tasks by automating process like scheduling appointments, billing, coding, transcription, documentation. It can also help optimize resource allocation, reduce costs, and also improve efficiency and quality of service. So what is the role played by AI in medical education? See, AI can help medical students learn and upgrade their skills and knowledge by providing personalized and adaptive learning content, feedback, and assessment. And AI can also help simulate realistic scenarios and cases for training and evaluation purposes. For example, AI can help teach radiology by providing interactive radiological tutorials and quizzes on medical image interpretation. And it can also simulate surgical procedures by using virtual reality and haptic feedback. Literally, this ChatGPT program, it has passed even USMLE licensing program. And how it is helpful in research. See, AI can help doctors conduct research and discover new knowledge by analyzing large and complex data sets such as genomic data, EHRs, clinical trials data, and biomedical literature. AI can also help design and conduct experiments, synthesize evidence, and generate hypotheses. See, for example, AI can help discover new drugs by screening millions of molecules of potential therapeutic effects. It is very helpful in drug discoveries. And it can also help identify new biomarkers for diseases by analyzing all this genomic data. It can analyze huge data at a faster rate than humans. So how AI can help us in medical diagnosis? See, AI can help doctors diagnose diseases and conditions by analyzing various types of data such as symptoms, medical history, physical examination findings, lab results, and medical images. And AI can also provide differential diagnosis, suggest additional tests or referrals, and estimate the probability and severity of diseases. For example, AI can help detect lesions or abnormalities in medical images, such as CTs, X-rays, MRIs, or mammograms, and using computer vision techniques such as deep learning. AI can also help diagnose skin cancer by analyzing images of skin lesions. It can diagnose COVID by analyzing chest X-ray and also voice recordings. So how AI is helpful in medical treatment? The AI can help doctors to prescribe treatments and medications by providing recommendations based on evidence-based guidelines, clinical trials data, drug interactions, and cost effectiveness. AI can also monitor the effects and outcomes of treatments and medications by tracking patient progress, adherence, So AI can treatment patient program. AI can help optimize radiation therapy for cancer patients by generating personalized treatment plans that minimize damage to healthy tissues. And it can also help us select best antibiotics for bacterial infections by predicting the resistance patterns of bacteria. So how it is helpful in medical management? See, AI can help doctors manage chronic diseases and conditions by providing self-care guidance, remote monitoring, feedback, and reminders to patients. It can also help coordinate care among different providers and settings by facilitating communication, information sharing, and workflow optimization. For example, AI can help manage diabetes by providing personalized advice on diet, exercise, and medication to patients. It can also help coordinate care for cancer patients by integrating data from multiple sources and generating care plans that align with clinical guidelines. So it can also help in prevention. See, AI can help doctors to prevent diseases and complications by identifying risk factors, providing screening tests, promoting healthy behaviors, and delivering preventive interventions. AI can also help predict the onset or progression of diseases and complications by using predictive analytics and machine learning models that learn from historical data. AI can help prevent diabetic retinopathy by screening images of retina for signs of damage. It can also help predict sepsis in critically ill patients by analyzing vital signs data. So what are the real examples? So right now, presently, so in work with AI in medicine. See, right now we have IBM version of AI. It's called as IBM Watson for oncology. They can provide evidence-based treatment options for cancer patients based on the genomic profile and clinical history. So it's a big role in oncology. And see, this one is developed by Google. See, there is a software like Google's DeepMind Health, which can detect eye diseases for retinal scans with high accuracy, even better than ophthalmologists. Okay, this Google's DeepMind Health software. And there's another program, AI system. It can predict severe sepsis in premature babies with 70% of accuracy. So this is another program which is called as ADL system. This can assess symptoms and provide personalized health guidance. So it is very useful in precision medicine. And right now, see, a lot of people are using, I personally also use this card, it is very good. So, and it is also approved by FDA. So using this AI tools, it is first approved by FDA in 2014. So we can do ECG monitoring and detection of atrial fibrillation. And even the recent REHARS AF study showed that the remote ECG monitoring with this cardiac in ambulatory patients is more likely to identify AF than routine care. Even Apple Watch is approved by FDA for this AF monitoring. And see, AI can very accurately predict the risk of cardiovascular risk. So they're used to predict the risk of CV disease, for instance, acute coronary syndrome and heart failure, better than traditional scales. In pulmonary medicine, see, right now, AI has a big role in interpretation of pulmonary function tests that has been very good in reporting these PFTs. And a recent study showed that AI-based software provides more accurate interpretation and serves as a decision support tool in the case and interpreting results from pulmonary function tests. So endocrinology, and this is very useful. See, right now, this IBM Watson, the AI version of developed by IBM. So they're using this AI technology in the Sugar IQ system. So they're helping the customers, the patients, so to predict these hypoglycemic episodes and repeated measurements. So when there are chance of developing hypoglycemia and so on with this continuous glucose monitoring technology. So in nephrology, so AI is very useful prediction of decline of GFR in patients with polycystic kidney disease, and also for establishing risk for progressive IgA nephropathy. So the role of AI in gastroenterology. So GAs, they're using convolutional neural networks and deep learning AI models in order to process images from endoscopy and ultrasound and detect abnormal structures such as colonic polyps. These artificial neural networks have also been used to diagnose GERD, atrophic gastritis, as well as they're used to predict outcomes in GA bleeding, survival of esophageal cancer, IBD, and metastasis in colorectal cancer, and esophageal squamous cell carcinoma. They are right now in real-world usage, all these AI tools. In neurology, see, Empatica has received FDA approval in 2018 for their wearable Embrace, which is associated with electrodermal captors that can detect generalized tonic-clonic seizures and report a mobile application that is able to alert closer relatives and also a doctor with complementary information about patient localization. Okay, it's very useful in seizure monitoring, these AI models. So even there are right now wearable AI sensors. They have proven very useful to qualitatively assess gait, posture, and tremor in patients with multiple sclerosis, Parkinson's, and also Huntington disease. In pathology, see, Page.ai, this is another AI tool. It has received breakthrough status from FDA for an AI-based algorithm that is capable of diagnosing cancer in computational histopathology with greater accuracy and allowing a pathologist to gain time to focus on important slides. So right now we're able to diagnose even pathology slides with this AI program. They're in right now real world usage. Radiology AI has a big role in this radiology, and a long-awaited meta-analysis compared performance of deep learning software and radiologists in the field of imaging-based diagnosis. Although deep learning seems to be as efficient as radiologists for diagnosis, the others pointed that 99% of studies were found not to have a reliable design. So this finding support the need of an extensive validation of AI-based technologies through rigorous clinical trials, which will happen in the near future. So this AI also helps us in error reduction. There is some evidence that AI can help improve patient safety. A recent systematic review of 53 peer-reviewed studies examining the impact of AI and patient safety found that AI-powered decision support tools can help improve error detection and also drug management. So a lot of time is spent during clinical trials assigning medical codes to patient outcomes and updating the relevant data sets. So he can help us speeding all these things. We can provide a quicker and more intelligent search for medical codes. And the two IBM Watson health clients, the IBM Watson is the AA program. They found that with AA, they could reduce the number of medical code searches by more than 70%. So it will improve the efficiency of clinical trials. And intelligent robotic surgery. AI tools can also perform surgical procedures with more precision, accuracy, and safety by using computer vision, haptics, or robotics. For example, there is an AI system that can assist surgeons in performing minimally invasive surgery by providing real-time guidance and feedback. And the AI tools are very helpful in this medical storage and also retrieval. And they're very useful in drug discovery because they can screen millions of molecules and they can suggest which are the best to take forward. And they're very useful in patient monitoring. And there is an AI system which can accurately predict severe sepsis in premature babies with 75% accuracy. Genetics. There's a program named Verily, which is developed by Google. It is very adept at predicting both communicable and hereditary genetic disorders. So what are some of the challenges? What are the limitations of AI in medicine? See, AI in medicine, they require high quality data that is representative, diverse, and unbiased. Our data collection and sharing can pose ethical and legal challenges such as privacy, consent, ownership, and accountability. And AI in medicine also requires rigorous validation and evaluation before deployment to ensure patient safety, accuracy, reliability, and explainability. However, there are no clear standards or regulations for testing and approving AI systems for medical use. And AI in medicine also requires human oversight and collaboration to ensure trust, transparency, and empathy. However, there are potential challenges in integrating AI systems with existing workflows, cultures, and expectations of doctors and patients. So what is the future? What is the future of this AI? See, artificial AI has unimaginable potential. So within the next couple of years, you can see it will revolutionize every area of life, including medicine. And I'm sure that artificial intelligence is not going to replace doctors. So they can never replace doctors. It is going to be like stethoscope of the 21st century. So unsuccessful collaboration between humans and technology could bring us the positive change in medicine that we also strongly wish. So it is never going to replace doctors. So it can't replace human touch, but it will help. It will augment our medical profession. It will help our medical profession. So something like a stethoscope helps us in diagnosing diseases. It also helps us in improving patient outcomes. So our future is connected. So future digital health will give us more health data than ever before, and AI will help us analyze to find new ways to treat diseases, to cut down administrative tasks, to streamline medical practices, to optimize both physicians and patient schedules. So right now, many universities are developing a program called Augmented Doctors. So they start a new medical curriculum. So it is something like both you'll get something like MBBS and BTech degree, like doctor engineering, so to answer the need of educating future medical leaders to the challenges of AI in medicine. So such curricula see a stronger approach to hard sciences. You'll be training physics, mathematics, and also the addition of computational sciences like coding, algorithmics, and mechatronic engineering. These augmented doctors could count on both the clinical experience with patients and also the training writing AI programs, digital expertise to solve modern health problems. So they can participate in defining digital health strategies for healthcare institutions, manage the digital transition, educate patients, and also educate their peer doctors. So what is the final conclusion? See, the future of AI in medicine is bright and promising, but also uncertain and challenging. See, AI has the potential to revolutionize healthcare by providing better, faster, cheaper, and more accessible services and solutions. However, AI also poses many risks and challenges that need to be carefully considered and addressed. And AI is not a magic bullet that can solve all the problems of medicine, nor a threat that can replace or harm human doctors. AI is a tool that can augment and assist human intelligence and expertise, but also requires human oversight and guidance. AI is a partner that can collaborate and cooperate with human doctors, but also requires human trust and respect. AI is a force that can transform and improve medicine, but also requires human vision and values. Thank you.
There's an excellent coverage regarding various aspects of artificial intelligence in medicine, sir, including orthopedics, risk assessment of sepsis, epilepsy, neurology, gastroenterology, whatnot. We are entering from Google to AI. Probably
yes, sir, literally. Now the era, even we can predict that the era of Google has ended, sir. See, right now, Google has dominated in the last 20 years for the search.
Entering from Google to AI.
Yeah. See, right
Yeah.
now, sir, for example, right now I want to go to a restaurant. See, if I go to Google and say restaurants near me, it will give me some millions of results. I need to go to the reviews. I need to see the restaurant websites and everything. I need to analyze, and it takes a lot of time to select something. See, the future of AA, the moment I say I want to go to a restaurant, so you can predict. So you can eat non-veg or veg. It knows what type of food I like, and it will say that you go to this restaurant, and you'll probably be solved. That's the future of search, sir. Not like throwing millions of results on your face and say, look at it. The future belongs to single answer and which is correct and which the user will like it. And that's the power of AI.
Right. Ramanmurthy garu, you want to say something? Rambabu garu?
Hello. This is Dr. Kulkarni from Mumbai.
Hi, sir. How are you?
I'm fantastic. So very nice presentation. There is always a fear in the minds of all the clinicians, especially primary care physicians, that whether AI is going to replace them. So, this is one of the fantastic steps which you have taken to take out the understandings about AI and all the applications which you are told, definitely they are at the our doorstep, and it will really modify our practice. Thank you. Thank you for a wonderful presentation, and you are always a star in this.
Thank you, sir. Thank you. So nice. Thank you, sir.
Dr. Subramanian, this is Ravi.
Hi, sir. Hi.
How are you?
Hi, sir. Fine, sir. How are you?
Good. So thank you for a good presentation. And obviously, I've been closely following AI and all those things. And it's as enthusiastic as it is, or as ChatGPT and all these are supporting. Obviously, there is a concern. But concerns apart, I think it needs more control. But also, it needs physicians like us be very involved. But then we cannot solve this problem without good tie-up with industry, and also trying to develop solutions that are personalized. So like mostly what I see where I practice is a huge problem, which is everywhere. And mostly for us in countries with India and backup population, there's a lot of power and data, but we don't know how to harness it. And towards that effect, I mean, I've been trying to do this since 2015, and that was when I started. I invested in a company for food tracking, but then it takes hard, and I lost a lot of money in that. But I did not give up, and now I'm working on another project that involves AI, by the way, and that involves metabolic health, that involves wound care, and artificial intelligence. So basically, I think I have that API 1 group. I posted a survey, and if you're interested, I will post it here too. But what it just comes down to us as physicians taking that mass medicine mindset and bringing it out and solving that one patient's problem. And one person cannot do it. And how much ever I try hard, it is that problem that we are facing across the whole spectrum. And nobody understands it better than the clinician, like you, sitting there with all this knowledge, struggling to convey it to your own team. And then also how to make the patient do that. And what is the difficulty of the patient? The AI can better understand and help us help the people we want to help, and that's where the power is. And I would if it's okay with the group, I would post that survey here, and only if it is okay. I mean, like, because I don't want to step on anybody's toes. Okay, and the idea is with a team approach. I mean, as a physician group, with a team approach, we can really solve the painful point of the patient. So that is what we have to concentrate on. All this technology is different. Real solutions only happen at the patient's clinical care. So all medicine happen at N of 1 level. And all this mass medicine mindset, we talk about a spectrum of 400 patients. I do clinical trials. But then when it comes to application of that solution, it makes it very, very hard. And I applaud what you're doing where you are. And that's why I keep following different things that you do. And hopefully I am trying to change healthcare, and you are. And I'm amazed by how, number one, Indian physicians are very innovative. That is number one. The power of us, each one of us in this group who are very enthusiastic, we should never short sell ourselves. And we can help change the world because we have the mass population and we can change it. But the power has to come to the physician. So that's what I'm working on. And hopefully, if you are okay, I will post that survey. And I will be coming to India on June 13th. June 3rd to 13th, I will be in Guntur Vijayawada area. And if anybody is around there, I would love to sit and chat with them. But obviously with Zoom, we can always do that anytime. Thank you.
Thank you very much, sir, for your kind message on the particular issue.
Sir, I think it's a wonderful presentation, and I think we are having the double-edged sword, sir. It's not because it's not only for in the practice. This now we can use more for the data analysis, research, and everything. But for the practice in clinical physician, still we need to do a lot, because AI in diabetes, in blood sugars. Now I am also in working with some of the things and getting the data collected. But our Indian patients, we see different varieties from illiterate to the highly knowledgeable software persons. So getting this kind of information to our patients, sometimes it will be devastating for some of the people also. For example, in your metformin, you were telling that what is the problems with the metformin, the lactic acidosis is also given. But in our practice, the number of lactic acidosis cases is very less. So for each and everything, patient will be getting again a very big questionnaire to the practitioner, so that again it will be a tough task for the doctors also. So we should have a separate OP for this kind of AI-driven patients. So we have to do something else also. But the point is well taken that we in the MBBS curriculum itself, we have to do something for these innovative technologies, the technological part. And otherwise, the medical engineering graduates already in the IIT Kharagpur, like that, this kind of courses have been started. So we have to train ourselves, and those who are really interested in updating their knowledge, definitely they can go for all these things. Thank you very much for being with us and innovative ideas. And over to Dr. Swami, sir.
Thank you, madam. Thank you for your kind words.
Sir, Avirav garu, anything else, sir? Sir, మీరు అన్మ్యూట్ చేసుకోండి సార్, అవిరావ్ గారు. శర్మ గారు.